Thank you for being here.
Thank you very much for a very generous introduction. It is a pleasure to be here, and I'm grateful on behalf of the ICS to the Hellenic Urological Society for allowing us to participate actively in this conference. So the topic given to me was surgery in neurourology, and what I will do in the next half an hour or so is to see what the urological conditions which we are trying to treat, why we are trying to treat them, what are our aims, what do the guidelines say, what are the options we have, and I'll in the end dwell about 5-7 minutes on what are the emerging treatment options which are in the pipeline, and we'll try to summarize at the end. This is a slide from ICS, and I quite like it. It actually summarizes most of what the neurourology actually says. On one hand, it's the brain conditions, and actually there are only 3 levels. What's happening at the brain level, suprasacral, and below the sacral maturation center, and then divided into congenital, then acquired, which are divided into stable and progressive. And if you just dwell a little bit on that, I think any treatment or any disease which neurological one can have can be put in one of these sections, and then we can very easily formulate a management plan. For example, come in the later on slides, the treatment of neurogenic detrusor overactivity, which is uncontrolled, will be different for a progressive disease like multiple sclerosis as compared to somebody who's got a stable spinal cord injury. This is an old slide, and I don't apologize presenting it, although it conflicts with what ICS says about the detrusor hyperreflexia. It is no longer used. But the reason I've put up this slide is that it again very eloquently describes what the dysfunction can be. And there are only 2. One is the bladder and the sphincter, and then above here, above the pontine maturation center, it can be overactivity. If it's a suprasacral, then either the bladder is overactive and the sphincter is overactive, dyssynergia, or if it is below this level, then everything is areflexic. And when we discuss the treatment options, we'll then find out that actually we can categorize the disease in a treatment pattern, and then we can formulate a reasonable, thought-out management process. So why do we want to treat neurological conditions? And although this slide goes for spinal cord injury, but it is true for other neurological conditions also. And we know that mortality after spinal cord injury was very high, and as we went down the last millennium, it is almost negligible today. And I think we can pat our backs because we as urologists and neurourologists have done quite a lot to help this group of patients. But I think it is not only important what the antibiotics catheterization did for us, but I think these last 2 are probably more important. It is the education to the patient, understanding what their needs are, what their support is, and probably most importantly in a neurological world, what the follow-up is. Because no matter what we do, short-term or long-term, if the follow-up is not there, there are lots of studies to say that the patient's outcome is not as good. So on that background, what are the aims of treatment? And the EAU guidelines summarize this very well. We want to restore the lower urinary tract if we can, achieve continence, but protect the upper tracts and maintain the quality of life. And how we do that, we have to consider what are our aims, but also what is the appropriateness and the durability of the treatment. And like I said earlier on, although our aim is normality, but there are differences between paraplegics and quadriplegics. So a treatment option for this lady who's got C3 spinal cord injury would be different than this gentleman who's got T11-12 injury, in the wheelchair and active. And this also goes true if you say that the lady has got advanced MS and the gentleman has got multiple spinal cord injury. So the treatment options need to be tailored according to the individual patient, although the presentation is the same as overactivity and incontinence. So what do the guidelines say? And there are lots of guidelines around, but do we really need to follow them? Probably yes, because a lot of effort has gone into them, and Apostolos and I sit on a lot of them. Is right? So, what are the treatment options? I mean, we are not going to discuss the non-invasive ones, but they're minimally invasive and surgical. And I think per the EAU guidelines, we quite easily divide them into failure to store. That means that either the detrusor is overactive, so we need to decrease the detrusor overactivity, or increase the outlet resistance. On the other hand, if the patient cannot empty the bladder, that means that can we enhance the detrusor contractility, or if the outlet is a problem, then can we decrease the outlet resistance? And it is all that reciprocal innervation controlled by the pontine maturation center between the detrusor and the sphincter, which needs to be managed probably at the same time. And when we discuss the emerging modalities, that is probably one of the limitations which we have got in neurourology. This is quite a good summary slide, again from ICI, which actually tells us of all the specialized treatment management we can have. And the first box is if somebody has got a weak external sphincter, so sphincters, bulking agents, slings are all the options which are available. On the other hand, if the sphincter is overactive, then sphincterotomy or stents is an option. What about if the detrusor is not contracting? Then one can have a sacral anterior root stimulator, or if the detrusor is overactive, then starting from botulinum toxin, going to cystoplasty are the options. So on the basis of that, if we discuss it a little bit further about the treatment options which we have got to decrease the bladder contractility, i.e. to treat the neurogenic detrusor overactivity. Botulinum toxin, I think all of us will agree, has revolutionized the treatment of overactivity, more so for neurogenic one, and especially for patients who have got multiple sclerosis or Parkinson's, because this is the group of patients we are reluctant to perform major surgery. The only treatment, botulinum toxin which is licensed is botulinum toxin, and these are the differences. We all know how it works. It's the light chain which is active, which is cleaves the SNAP25 and prevents the formation of snare complex. And I think apart from the mid-urethral slings, which we have discussed earlier on, I think we have got the most evidence over the last 10 years, randomized trials, observational studies, retrospective studies, proving the efficacy of botulinum toxin. I've just picked this one because on the basis of this cruise study, the Dignity one, botulinum toxin got the license to be used for neurogenic detrusor overactivity, and we know that 200 units is licensed to be used for 30 injections, intradetrusor, trigone sparing. The effect lasts on the average of 6 to 9 months, and we know from a number of studies that the repeated injections are beneficial, 1, 2, 3, 4, 5. I think including myself, we've all injected the same patient with more than 10 injections, and they are still beneficial. So what to do if the botulinum toxin is not working? What are the indications of clam ileocystoplasty? And the main indication is a refractory neurogenic detrusor overactivity, which is bothersome for the patients from the patient standpoint with incontinence. From a physician standpoint, if there is damage to the upper tracts, if they are under pressure, then cystoplasty with or without ureteric reimplant can be done. And here one can see the bladder has been bivalved. A 15 to 25 piece of ileum is isolated, and then it's stitched to the bladder like a clam. I'm not going to discuss the operative details, but like any operation, there are some contraindications, and I put a question mark as relative because if somebody's got an intrinsic bowel disease, renal impairment, these are all relative contraindications. Going back to initially what I said, if they have got proper follow-up, then they can be offered this treatment therapy. Even refusal to SIC is not an absolute contraindication, at least to start off with. If appropriate, follow-up is available. On the early complications, the only thing I have highlighted is the VP shunt in spina bifida patients, because sometimes if you're not aware, then there's up to 20% chance that it can get infected. The more important is the delayed complications, and there are a number of them, but the important ones are the mucus production and the bacteriuria, which almost all of them will get, but only less than half will be symptomatic. Going back again, a regular follow-up will be able to pick this up, and patient will be reassured that not every bacteriuria, especially which is asymptomatic, needs to be treated. The same goes about metabolic complications, and almost all of them will have metabolic acidosis, but that does not need to be treated. Again, we need to follow them up at least yearly with chloride and bicarbonate evaluation. There's a small risk of developing cancer, which can be after up to 20 years. Again, they need to have a regular follow-up. There is no consensus in the literature whether they need to have yearly surveillance cystoscopies. Including our group, we used to do that, but now we have stopped doing it. And now what is recommended is that any change in their symptoms, especially getting urinary tract infections or hematuria, they should undergo cystoscopy. What about if they cannot catheterize MS patients or spinal cord injury patients who are wheelchair-bound? Metrophenol is an option which was popularized in 1980s by pediatrician Mitrofanoff, and that is the appendix can be isolated. However, nowadays a lot of patients have got appendectomy, and in that case we can take two small pieces of small ball, 2 centimeters, roll it in a tube, and then make a channel out of that, which is again very, very effective. Lots of studies have shown that the success rate is up to almost 100%, albeit with almost a 50% revision rate of either stenosis, incontinence, or difficulty in catheterization. But the patients, and lots of studies have shown that it's a very, very satisfactory procedure. What about if the patient has a weak outlet? Sphincter, slings, and bulking agents are all options. We have heard a little bit earlier on about the sphincters and slings. They are still very good options for neurogenic patients also. The success rate can go up to 90%, but there's a reoperation rate of around 50%. And the complications, same as non-neurogenic patients, but the rate is a bit more: erosion, infection, malfunctioning, or incontinence. And a lot of groups have shown that the long-term results are good, but there's a 50% continence rate. But more importantly, the 2 points of discussion are whether it should be placed at bulbar level or at the bladder neck level, or it should be done open or robotic if it is at the bladder neck level. And Shati Castell's group have actually published this very good study. In their hands, the robotic one worked very well. And I think the way forward probably would be either laparoscopic or robotic bladder neck insertion in the patients, especially those who are wheelchair bound. What is the recommendation for mainly females? It is the slings, autologous slings, which are effective for long-term control, albeit at a high rate for stress incontinence. The erosion rate for slings are more. Our group has published long-term results of TOT in this group of patients, and we have shown a 70% success rate if the selection is appropriate. What about bulking agents? Again, there are very few reports. The results are not as good, only a 33% success rate. We have published on the with PDS, which is macroplastic, with a good success rate. However, the new kid on the block is Bulkamid, and we wait to see whether the results are any better in this group of patients. So in summary, for this part of the talk, for bladder overactivity, it is the botulinum toxin to start off with. Otherwise, in the refractory group, enterocystoplasty. And for incontinence, for females, it is the autologous sling, and for males, it is the artificial urinary sphincter. What to do if failure to empty? And the only therapy which we have got is sacral nerve stimulation. I don't know your experience about this, but I think this is the single most good operation which we had, albeit at the cost of posterior rhizotomy, which made the overactive bladder an underactive one, and the patients were emptying the bladder very well. More than 2,000 implants have been undertaken, but this very benefit to convert an overactive bladder into underactive is also a disadvantage because the patient lose erections, and more importantly, in this era of stem cell therapy, patients quite rightly probably do not want to have any invasive surgery. We've seen these benefits of voiding spontaneously, no urinary tract infection, patients become appliance free. It can be used for bowel and erectile dysfunction also. Coming to the failure to empty procedures, and there are three. One is external sphincterotomy, stents, and botulinum toxin A. I think one of the disservice which anybody can do to these patients is to do a sphincterotomy without confirming that the convening drainage system will stay, the skin will be fine, and I think these needs to be done, and obviously this is reserved only for males. And we always ask a question, is it better than a catheter? Probably it is in selected group of patients. With those caveats checked, it's a good procedure. Nowadays, laser sphincterotomy can be done. Reoperation rate is reasonably high and there can be complications with it. But like sacral stimulator, it is not done that often nowadays because again, it's a destructive procedure. And all of us have toyed with the idea of both temporary stents, which is mammocath, and permanent stent, which is a wall stent with good results shown from our team also. But they have all fallen out of favor for a variety of reasons, not the least that if one needs to do a cystoscopy, it is difficult to go anything with more than a 17 or 19 sheets, so even the small stones or biopsies cannot be done. So what about botulinum toxin? It's a reversible procedure. It's not as successful as in detrusor, but we do not know the dose, 100 to 200 units, 4 mils at 3, 9, 6, and 12 o'clock. And the results are variable. Bridget has shown 95% success, but Gilligan shows 0%. And that is actually showed in other studies also. Some have said that it works very well. But I quite like this Cochrane review, which has said that small studies have shown some benefit. But I think the downside of botulinum toxin in detrusor is that at best it works for 3 months. So I use it from time to time to see if the patient likes it, the convening sheet will stay on, and then you can have a permanent procedure like a sphincterotomy. So on that background, I'll come, the last part of the talk is to see what are the emerging therapies. Can we, for crystal ball to look into the future? Because all the current options have got limitations. The minimally invasive therapies like botulinum toxin needs to be repeated. Cystoplasty is a major intervention. There's not a single treatment option, and quite often we need to have multiple therapies. So these are emerging modalities, but they have been emerging for the last about 10, 15 years, starting from sacral nerve stimulation, which is probably the one which has got the most promise, tissue engineering, lumbar to sacral rerouting, neuroprosthesis, and the new kid on the block is transcutaneous spinal cord stimulation. I'll see a few words about all of them. Initially, for sacral nerve stimulation, it was thought that this is not going to work for neurogenic patients, and it was omitted from most of the trials. But there's a good review from Thomas Kessler about 10 years ago, and you'll see apart from the pure spinal cord injury patients, the success rate is around 60 to 80%, which is more or less the same as the non-neuropathic group. On the basis of this, I think K.D. Siever did this very good test because, like I said at the start of the talk, our main concern is the neurogenic detrusor overactivity, which can affect the upper tracts. And he did this very eloquent study in 16 patients with almost a 2-year follow-up that they had SNM implanted very early on and showed that the detrusor remains acontractile and they remain continent. Whether this is going to have any long-term benefit needs to be seen, but that is one of the roles of sacral nerve stimulation early on, is to prevent the formation of or appearance of detrusor overactivity. It has also been done in multiple sclerosis patient, where it has shown that good selected patients, the number of maturation goes down, the voided volume goes up, and the need for pads go down. So in multiple sclerosis patients, those who are relatively stable and don't need an MRI, this is a good therapy to make them continent. On the basis of this trial, there's a neurogenic bladder group in the United States who have now started to do a randomized trial to see whether we can suppress the neurogenic detrusor overactivity earlier on and whether that will have a beneficial effect over the long term. And this trial has just started. Probably it's going to take about 10-15 years. But if it's proven that suppressing the overactivity earlier on will be of benefit to the patients with less complications, this is something which we look forward to. So I think for SNM, probably it is the most worthwhile therapy in minimally invasive options. Patients might void without catheters, but quite importantly, it might help with bowel and sexual dysfunction, albeit one needs to be careful that in patients who have got progressive disease who require MRI, it is not for the time being, although we know that both Medtronic and the new company, the Exonics, are now bringing out the implants which are compatible with MRI, although it's still not a completely established therapy. What about tissue engineering? And I'm a bit cynical about it. We know that Atala did about 20 years ago, implanted these 7 patients with collagen scaffolding and showed that the bladder compliance is better and fill pressure goes down, capacity goes up, but we have never seen a follow-up study. And like I said earlier, I think one of the issues with the tissue engineering is that it can only look after either the bladder or the sphincter, and in neurogenic patient we need the reciprocal innervation. So although it is a promising concept, but there are lots of unanswered questions, and probably it is only for the urothelium, and we might decide that it's only the urothelium if we can decrease the overactivity or sensations at that level. That is the way forward, because we know that otherwise there's a 70% graft rejection rate or contraction rate. What about lumbar to sacral rerouting? This is quite an interesting concept. Essentially, what it does is to bypass the wherever the transaction is, and the theory is to establish a skin, spinal cord, bladder route. So once one needs to void, that particular dermatome is scratched, which causes the contraction. And Zhao in China did a good experiment looking at 92 patients and showed that in children that all the overactivity was abated. Very interesting trial, very promising, and hence it's taken up with the North American arm. And Peters did a trial on 9 patients, and the results were not as good, but there were lots of complications that no patient achieved continence. There was a weakness in the lower limbs. One child developed a foot drop, and voiding was not studied in this, and there was no way to control the DST. So although it's an intriguing concept, one fails to understand that just doing one at the S3 level, how is that going to make the whole of the bladder contract, and what about the dyssynergia? So I think in the European journal, there was a good words of wisdom that the Chinese results have not been replicated, and there's a lot of complications attached, so this should be reserved only for research protocols, at least for the time being. What about neuroprosthesis? And this was a very good or conceptually good trial by Possover and Bridget Church done about 10 years ago. And what they did was they implanted in 3 patients these 8 nerves at the 8 implants, Brindley type, at the level of pelvic and sciatic nerves. And what they showed was that the bladder emptying could be done, and there was a lot of benefit with sexual and bowel functions also. But again, this was published in 2010, and there has not been any follow-up studies. So last but not the least is a proof of concept of this transcutaneous magnetic stimulation of the spinal cord. I think the biggest positive for this is a non-invasive stimulation, and what it has shown is that if it's done for weekly for 16 weeks, and at least this group of patients, albeit on 5 patients, they managed to pass urine spontaneously without the need for self-catheterization. So I think this is a promising therapy. So in conclusion, I think the symptoms of neurogenic bladder dysfunction can be controlled according to the aims set by the EAU guidelines. There are a variety of minimally invasive and major surgical techniques are available, but the most optimal therapy must be done for an individualized basis as per the MDT, looking into, like I started off, whether the disease is stable or progressive, and what are the options, whether paraplegic or quadriplegic. I think of the emerging modalities, probably it is the neuromodulation which has got the most promise. Most of the other ones, including lumbar to sacral routing and the regenerative medicine, are still very, very experimental. And we need well-conducted research. I, for one, am not a firm believer or subscribe to the idea of doing randomized trials in neurogenic patients. What I feel more important is that we need to have proper registries where these patients are looked on a prospective basis so we can have long-term 10, 20 years data. And I think, like Apostolis said earlier on, I quite believe that it is the pontine maturation center and the higher centers which we need to look at more in neurogenic conditions, especially the non-spinal cord injury ones, and probably there's a lot of role for functional MRI in the future. Thank you very much, and I'd like to end up with saying that I am again grateful on behalf of the ICS that I've been given this opportunity, and I'd like to say that ICS is probably one of the only multidisciplinary organizations in which we have got not only the surgeons, but physicians, physiotherapists, urologists, urogynecologists on one hand, and physiotherapists, continence advisors and healthcare assistants with the researchers on the other hand. And I will encourage all the young Greek urologists and physiotherapists to join. There's a reduced rate for nurses, and for the urologists, I would like to invite you to submit your abstracts. The closing date for the next year is for March 1st, April, and the 48th meeting will be in the beautiful city of Gothenburg in Sweden, and we'd like to see as many of you as possible. Thank you very much.